Well, thank you, Anita. I've been charged with everything you want to know about severe ulcerative colitis in 10 minutes, so hold on. So this is a case, a 25-year-old female, recently diagnosed, started on steroids, and then does not respond, essentially has increased bloody bowel movements, and has some features, elevated temperature that's suggestive of severe disease. If you look on the left-hand side, here we see the typical admission X-ray with dilatation of the bowel. Good radiologist will tell you the extent, and that she does have pancolitis here. And when we do a limited endoscopic examination, we see Mayo 3 changes. So this is an area where we don't have a lot of data. So I'm not encumbered by data, but I'm not going to extrapolate based on my own opinion too much here. And I think we can go back historically to recognize that a lot of what we learned about this is back in Oxford in the 1950s. And I'm just showing here True Love and Wit, and those are the criteria that you all grew up within your gastroenterology training program. And they really haven't changed. This really defines it. Some people who are sarcastic might say that, well, the definition of ulcerative colitis is if you're wearing a white coat, the patient has severe ulcerative colitis. But it's useful to measure these things, and here's why, because if you look at the severity, the more features, the criteria that you have, the higher the colectomy rate. So this is a useful measure. And I think one of the themes in managing severe ulcerative colitis is you have to have metrics. And here our endoscopic scoring system is also useful. You're all capable of scoring the Mayo Clinic score reliably, and it's been shown in several cohort studies that severe endoscopic disease activity is a predictor in the hospitalized patients. So I would recommend doing this procedure in your patients. So there's a long shopping list of things with regard to standard management. I'll just summarize by saying, you know most of these things. Essentially, it's adequate hydration, making sure that the patient has sufficient volume, the patient is not hypokalemic, and initiating corticosteroid therapy. We've come to understand that C. difficile infection is a major problem in these patients, and we should all take the necessary steps to exclude that. And cytomegalovirus by biopsy, again, another really important rationale for performing endoscopy. And then thinking forward, pre-screening test if you have sufficient time for secondary therapies such as infliximab and cyclosporin. Okay. So really, the modern therapy of IBD, if we talk about sequential approach, it's intravenous hydrocortisone or methylprednisolone. Personally, I tend to use methylprednisolone at a dose of 60 milligrams as a standard therapy because it's more potassium sparing. It was really this landmark study which got us into the therapeutics of the disease. And really, that is the cornerstone of therapy. Now, apart from C. difficile's recognition of its role as a provoking factor, I believe that the most recent advance in the therapy of ulcerative colitis is recognizing the risk for thromboembolic disease. And I bet if I went and audited your practices with regard to this, that most of you, meaning the majority, are not doing this. And it's logical, perhaps, that giving anticoagulates to people who are bleeding might be a bad thing. Now, I can tell you that we did look at this in meta-analysis because heparin therapy, some of you may remember, was advocated as a potential therapy for ulcerative colitis due to its nonspecific blocking of proteins. Well, there was no evidence that, paradoxically, using heparin in the context of severe colitis increased bleeding rates. What it does do, however, is prevent against thromboembolic disease. And I think maybe the thought balloon some of you are having is, well, I've never seen a clot in an ulcerative colitis patient in the hospital. The problem here is the rate in those patients is only about 3%, only. But if it happens to your patient, it's devastating. If you have a major thromboembolic disease, such as sagittal vein thrombosis or a severe pulmonary embolus. So we're recommending that for all patients in national guidelines. So back to the case, this patient is admitted, started steroids, but really doesn't respond, which brings us to the role of secondary therapy and our game planning. And the first question is when? Well, there have been various cohort studies, retrospective cohort studies addressing this question, and I think to cut to the chase, it's really the 3-day rule. So your patient should be improving by 3 days of therapy, and that really in the Oxford rule means below 6 bowel movements per day and a CRP of less than 45. There are various variants of this, but I think the key decision-making time point is 3 days. That's the thing you need to remember, is don't wait till a week of corticosteroid therapy before deciding the patient's refractory. Which gets us to the next level, which is choice of rescue therapy. And I'm going to just say that, in my opinion, cyclosporin is of historical use only. I'll always remember this paper in the New England Journal of Medicine because it appeared in the same edition of the journal as our 305-patient 2-year study of cyclosporin. This was a patient with experience of 20 patients in a randomized controlled trial. And guess which study got all the press? Ours was negative, this was positive. So that was a very dramatic result with 4 milligrams per kilogram. We came to understand that we could use lower doses and that lower doses were safer. So if you're going to use cyclosporin, use the 2 milligram per kilogram IV dose. The major problem with cyclosporin is infectious complications. In the modern era, we've used exclusively infliximab for the most part, and that therapy really came to be from this paper by Gunnar Järnero in Sweden, betamethasone versus infliximab, showing a clear advantage over corticosteroids in a head-to-head comparison, relatively small study again of about 45 patients. I think the most striking development in understanding the therapeutics of IBD in general has been therapeutic drug monitoring and recognition of high drug clearance with monoclonals. And the patients with severe ulcerative colitis are really the poster child for that problem. And here, showing this concept that these patients have high amounts of TNF, so there's a TNF sink that will gobble up your infliximab therapy. The patients are clearing the drug rapidly in the liver and spleen, the shark, and they're also clearing drug through an atypical mechanism through the gut. So logically, perhaps we need higher drug concentrations. And there's limited data regarding this. There's no high-quality randomized controlled trial. But certainly many of us have changed our practice on the basis of the circumstantial evidence, and we're giving intensified dosing schedules, recognizing that the patients with high CRPs and low albumins are really the patients that clear the drug quickest. When you see the CRP dropping initially, that's a good thing. When it goes back up, the V is not for victory, okay? That means you're not adequately suppressing TNF and you need more drug. The echo statements really have commented you can use either drug, so what about a head-to-head comparison? There's only one study in the literature, and that's this French multi-center study. This was an amazing tour de force. It couldn't be done anywhere else except in France. It's over 100 patients randomized to infliximab or cyclosporin, and the results of this study really, although the New England Journal decided that it wasn't a properly done non-inferiority study, which would require randomization of perhaps 400 patients, this is as good as it's going to get in this condition. And you can see for yourself, without any p-values or confidence intervals, that really wasn't a choice here. Anyone who's used cyclosporin knows that it's a tricky drug to use in comparison to infliximab, which is more fire and forget. Not a lot of monitoring in regard to that choice versus infliximab, versus cyclosporin, which is complicated. And here are the results: colectomy-free survival. The safety, there wasn't much to choose between the two drugs. In the observational study, cyclosporin has studies, there's quite a few in the literature, has much more problems with regard to safety. So most of us have changed. So that raises the issue, if you fail one of those therapies, what about the other? And here I think the message is don't do this at home, okay? This is not something, all this does is delay the need for colectomy, and it is associated with increased morbidity. So if we go back to this case, the patient didn't respond to steroids, was given Remicade, and actually responded, and based on the 3-day rule. I'm not going to talk about surgery. That would be most inappropriate given the other speakers in the audience. But I will just say that surgery, if you actually start corticosteroid therapies, a surgeon should be involved. Certainly, if you're starting salvage therapy with infliximab, a surgeon should be involved, and really delaying colectomy is the most common practice that results in morbidity. And just to give you a sense of this, this was a recent meta-analysis that shows clearly that the longer you wait, the higher the mortality rate is. So this is really a fundamental message. There's nothing wrong with using salvage therapy, but use it early at 3 days, don't wait. And get your surgery at a major center. So, and this is a recurring theme in surgical series, that the longer you wait, the higher, or the smaller, fewer number of cases done, higher the rates of complications. So, pretty simple message. Use objective criteria, true love wit, decide the patient's sick enough for hospitalization. Use the 3-day rule, and then start infliximab in most cases, and don't use multiple salvage therapies. And early surgery is, in the refractory patient, is a life-saving procedure. So I'm going to conclude there. Thank you.